Acute myeloblastic leukemia, or AML, is one of the most aggressive and clinically important leukemias you'll encounter. In this video, we'll walk through everything: history, physical examination, investigations, management, complications, and prognosis, in a way that makes sense for both exams and clinical practice. Let's begin with the history. Patients may sometimes be asymptomatic, but the common complaints include fever, fatigue, easy bruising, gum bleeding, weight loss, and sometimes skin rashes. Less commonly, patients may present with headache, confusion, or frank bleeding. When you dig deeper, you may find pallor, petechiae, swollen gums, or even signs of infection in the past few weeks. Remember, a family history of leukemia is uncommon, but risk factors include prior radiation, chemotherapy, or a pre-leukemic syndrome. Moving on to the physical examination, look carefully for pallor, petechiae, and ecchymoses. Oral examination often reveals gum hypertrophy and bleeding. You may notice leukemia cutis, which are skin infiltrations by leukemic cells, or retinal hemorrhages on fundus exam. Lymphadenopathy is less common but possible. Some patients may have extramedullary masses called myeloblastomas, which can involve skin, bone, or even the spinal column. Splenomegaly and jaundice are less frequent findings but should not be missed. Now, let's talk about the laboratory investigations. Basic studies include a complete blood count, which often shows anemia, thrombocytopenia, and circulating blasts. Electrolytes may reveal spurious hyperkalemia if the white cell count is very high. Always check renal and liver function tests, uric acid, and coagulation profile, because these patients can easily tip into tumor lysis or DIC, especially in acute promyelocytic leukemia. If febrile, send blood, urine, and throat cultures. For specific diagnostic tests, bone marrow aspirate and biopsy remain the gold standard. Morphology, cytochemistry, cytogenetics, and flow cytometry for immunophenotyping. Now, management. This is a true medical emergency. While confirming the diagnosis, you should start supportive measures immediately: hydration, electrolyte correction, infection control, and allopurinol for tumor lysis prophylaxis. Correct anemia with red cell transfusions, and give platelet transfusions if counts fall below 10 to 20,000 or if there's active bleeding. Always be on guard for disseminated intravascular coagulation, especially in APL. Once the diagnosis is clear, the treatment moves into induction, consolidation, and post-remission therapy. In acute promyelocytic leukemia, the cornerstone is all-trans retinoic acid, or ATRA, combined with an anthracycline-based regimen. Consolidation with at least 2 cycles is necessary, and maintenance therapy is often recommended. For AML in adults younger than 60, the standard induction is the 7+3 regimen: 7 days of cytarabine with 3 days of an anthracycline like daunorubicin. Older patients usually receive a lower intensity regimen. Poor risk cytogenetics or prior myelodysplastic syndrome patients may need stem cell transplant or enrollment in clinical trials. If remission is achieved, consolidation is usually with high-dose cytarabine in younger patients, or stem cell transplantation for those with poor prognostic features. Relapse is managed with salvage chemotherapy, arsenic trioxide for APL, or stem cell transplantation. Now let's talk about oncologic emergencies in AML. Patients may develop leukostasis with CNS or pulmonary symptoms, renal or liver failure due to infiltration, or spinal cord compression from myeloblastomas. These require urgent initiation of chemotherapy, sometimes along with local radiotherapy. As for drug side effects, cytarabine commonly causes severe cytopenias, infections, alopecia, liver dysfunction, and ataxia at high doses. Anthracyclines are notorious for cumulative cardiac toxicity. And ATRA may cause retinoic acid syndrome with fever, respiratory distress, edema, and renal failure. This requires immediate high-dose steroids. Follow-up during therapy is rigorous. Blood counts, renal, and liver functions are checked frequently, and bone marrow is reassessed around day 14 to 21 of induction to confirm response. Neutropenic fever is aggressively evaluated and managed. Finally, the complications and prognosis. The most common complications are infections, bleeding due to thrombocytopenia or DIC, drug toxicities, and relapse. Prognosis depends heavily on age, cytogenetics, and prior history of marrow disorders. With chemotherapy alone, long-term survival is around 25 to 35%, but outcomes are better with stem cell transplantation. APL remains the best. So, to summarize, acute myeloblastic leukemia is a rapidly progressive but potentially curable malignancy if diagnosed early, treated aggressively, and followed closely. Always recognize the emergencies, initiate supportive care early, and remember that cytogenetics is key to prognosis. If you found this video helpful, don't forget to hit the like button, share it with your friends, and subscribe to Scalpel and Scribble for more high-yield medical content. See you in the next video.